I'm going to just whiz through this very quickly so that actually we can do some talking about answer some questions. Right, crisis. We had some quite heart-rending feedback to the strategy when we asked patients and carers across the city of their experiences. And despite everything that's been said this afternoon, what we still hear is how people felt really abandoned and unsupported and unable to access support, which is just so heart-rending to hear the quotes. Crisis can look like lots of things. It can look like, you know, the phone call from a family member saying, I can't do this anymore. It can be recurrent falls. It can be very practical things like developing pressure sores because the person's not moving anymore. It can be the disinhibited behaviours, the aggression that we've touched on already this afternoon. The commitment, the strategy commitments have been updated and we're due to launch that in a couple of weeks, but we have made a fresh commitment to try and ensure that individuals with dementia receive a timely and appropriate response, whether or not they're at home or in a specialised setting. We already know this fact. We've got hundreds and hundreds of beds used up with people in dementia in the city and across the UK, with prolonged stays in hospital because of ineffective, problems with discharge to safe environments. Again, we've touched on this around what causes crisis. It can be stress, carer stress, interim illness and delirium, and it can be end of life, and recognising end of life in dementia can be challenging. Delirium, the QR code on this slide is the Pinch Me, the lovely acronym which can make you think about all the things that can cause a delirium. Obviously, we're much more, familiar with that now in terms of recognising delirium, hypoactive and hyperactive delirium that can present in old, frail people and people living with dementia. So it's always worthwhile thinking about, and it is quite a useful acronym. Drew and Sophie have talked admirably about the excellent service the short-term intervention service provide. Personally, I've had really fantastic experience of using that service, and just as Sophie was describing, their ability to spend the time doing the networking for us, which saves us vast amounts of time, quite frankly, is brilliant. Just want to touch on this before we go to questions, which is another QR code, which is the acute deterioration pathway. We created this last year, and it came from a case that I'd had, but I knew that a number of you and the colleagues across the city had had. When you have an acute deterioration in dementia presentation, and really what I wanted to do was work with colleagues across everything. We had South Yorkshire Police, the ambulance service, the out-of-hours service, the liaison psychiatry service. We had everybody involved in a discussion about who should do what in this situation. Really what I wanted to do was empower us as healthcare professional colleagues to consider that it is okay to use a sedative in the short term if it buys us time to try and evaluate someone's situation. So I wanted it to sort of empower people to think, well, I could hold this situation with a bit of lorazepam while I try and work out what is going on here, rather than people being pinged inappropriately or potentially unnecessarily into a hospital bed where things are just going to get worse. But the other reason to do it was to just ensure that we understood who had to do what. And it came out of a patient I had who'd become very aggressive in a care home. The police had turned up, the paramedics had turned up, neither of them would do anything. I couldn't get near enough the patient the patient wouldn't take anything orally, and they were all saying, well, we can't do anything. I was like, what do you want me to do, dart him? It was just ridiculous. And so the pathway basically ensured that the police understood that if a patient was posing a danger to other people, even if they're within a care home environment, that their job was, because they are trained to restrain people, to restrain that person and get them to a safe environment where we can safely administer a suitable sedative to manage the patient. And so it was just to get the paramedics and the police to work together alongside GPs to manage a situation if we cannot contain it and control it, keeping the patient in the home environment. So if any of you haven't seen that protocol, it is there for us to use and encourage our colleagues to stand by that. So preventing a crisis, we all know about that, and Drew touched on that as well. So what can we do? What can we do to think about it? Is talking about advanced care planning, potentially making contingency plans. If you've got a carer who's also frail, what happens if? What happens if you fall over and break your leg? You know, what other numbers have we got on the system? Who are we going to call for you? How can we put things in place? Recognise that obviously end of life's coming next, so this is a sort of link slide in. Sometimes a crisis in dementia can represent a deterioration towards the end. It's really hard, and again, you know, you all know this, trying to recognise those patients that are actually deteriorating towards the end of life. You know, is this just a hypoactive delirium, or are they dying? Often it's a case of watch this space and get support from everyone you can. Lynn's here somewhere from St Luke's, and St Luke's and the palliative care team have increasingly been helping us with managing patients with dementia. So I'd encourage you, if you haven't done that already and you are struggling with someone with advanced dementia, you think that they might be reaching the end, St Luke's can help us with those guys as well. They're not just here for our other groups of patients.